Welcome to our third webinar organized by the CovidNigerianMedics. CovidNigerianMedics set up at the beginning of the pandemic to raise funds to provide PPE to all the states in Nigeria at the peak of the pandemic. We have found webinars present opportunities for discussing and learning about the issues that arise in the delivery of healthcare in Nigeria. Today's webinar is on the challenges and opportunities in the delivery of acute and emergency care in Nigeria. We all know that in an emergency, patients, regardless of their social status, have the same access to the facilities in healthcare. And most of us have some personal experience of a loved one who has received less than optimal care. We all know that there are emergency conditions that will have a similar outcome in whatever part of the world they occur in, but there are those that we know will likely have a better outcome with the right care and facilities in place. Today we have Mr. Jude Onwubaramuko, who is moderating alongside with me. And we also have Drs. McArthur and Badamasi, who are presenting the challenges in delivering emergency care. Dr. Habib will be presenting the opportunities, and the panelists include Dr. Olajide, Dr. Sadiq, and Dr. Sadiq. You're all welcome to our third webinar.
Thank you.
Thank you.
Thank you.
Hi, everyone.
So I have Dr. McArthur and Badamasi presenting.
Good evening. I am Dr. McArthur.
And I'm Dr. Samira.
And we're going to present a case of a patient managed in Biological Teaching Hospital, as well as discuss challenges that we face in acute management and emergency care also in Biological Teaching Hospital. So we're going to go through this case in 7 minutes, so please bear with us. In the accident and emergency of Biological Teaching Hospital at 5 p.m. on Thursday, we admitted a 64-year-old female who presented with high-grade fever, body weakness, and vomiting of 1 day with associated polyuria and polydipsia. She had a past medical history of type 2 diabetes and hypertension. Also, she had a background chronic heart failure. Okay, so on examination, she was found to be morbidly obese in respiratory distress with an SpO2 of 94%. Her temperature was 36.8 degrees Celsius, and she was found to be dehydrated. She was conscious but confused with a GCS of 14/15. She had a pulse rate of 136 beats per minute, a BP of 110/70 with normal heart sounds. But with a normal first heart sound, however, she had a loud A2. On her chest, we found a respiratory rate of 36 cycles per minute with widespread crepitations. She had an obese abdomen. There was no area of tenderness and no organs were palpably enlarged. So the plan was to do an urgent random blood sugar, which was done. We found an unrecordably high blood glucose using a glucometer, that's the pinprick or the finger prick test. An urgent urea electrolyte and creatinine was ordered for urinalysis, ECG, echocardiography, HbA1c, a fasting lipid profile, and complete blood count. So she was given normal saline, 500 mils 8 hourly. I mentioned she had a background of chronic heart failure and was on medication for that. So we didn't give the usual IV fluid. We gave 500 mils 8 hourly and soluble insulin IV, 6 international units. Her weight was estimated to about 100 kg. So we used the lower limit, 0.05. international units per kg. So we arrived at 6 international units. So we gave her hourly. That was the plan anyway. Until random blood sugar would be about less than 14. She was to continue her prescribed antihypertensive. So we got a UNE result about 5 hours later, and this was the result. Bicarbonate 22 millimoles per liter, sodium of 126 millimole per liter, chloride of 84 millimole per liter, potassium of 4 millimole per liter, urea of 93 millimole per liter, and creatinine of 186 micromole per liter. We got the serum glucose from the lab, and the result was 50 millimole per liter. So the calculated osmolality was 319 milliosmoles with an anion gap of 24 milliequivalents per liter. On her urinalysis, were 3 pluses of glucose, 1 plus of protein, and 3 pluses of leukocytes. There were no ketones. On the complete blood count and differentials, there was neutrophilia and slight lymphopenia, not so significant. So unfortunately, over 14 hours of hourly 6 international units insulin, glucose was still found to be unrecordably high at 8 a.m. The patient had tipped into altered sensorium. A GCS had depressed to 10/15. She had developed partial seizures and a facial nerve palsy. So she was transferred to the female medical ward for an endocrinologist and cardiologist to review. In the female medical ward at 8 a.m., after she was transferred, the endocrinologist as well as the cardiologist decided to use the higher limit this time around. So the insulin requirement was calculated using 0.1 units per kg. And we arrived at 10 international units. So she was given hourly. She was supposed to be given hourly. So she got the first dose, but after an hour, it was still found to be unrecordably high. So the dose was then doubled to 20 international units hourly. However, after the next hour, the sugar had crashed to 29.7 millimole per liter. So we came down back to our initial 10 international units hourly until random blood sugar is less than or equal to 14. And we were able to achieve that by 3 p.m. when it came down to 11.3. As for the seizures, we gave IV diazepam 10 milligrams to support the seizure, and she was placed on sodium valproate 250 milligrams PD as prophylactic. She was placed on NG tube. An NG tube was passed for feeding and medication, and a urethral catheter for strict urine input and out monitoring. And the antihypertensives were discontinued. Okay, as I mentioned, at 4 p.m., random blood sugar became 11.3. So we changed her to IV fluid, 5% extra saline, 500 mils, 12 hourly. And increased the insulin to 12 international units. A requirement was calculated for 4 hourly management, 4 hourly insulin administration until the patient could tolerate NG tube feeding. So the problems that we had, the high serum glucose level. Initially, we couldn't get the serum glucose from the lab. So we used the glucometer, and the glucometer we use cannot give any reading that's higher than 33.3 millimoles per liter. So I guess that's why we kept getting unrecordably high. And the late UNE results that we got about 5 hours later, so we couldn't do much about the electrolytes. Also, we had no available infusion pump. We also do not have as much staff. we had only 2 nurses on rotation and about 20 beds occupied with patients. So these are mainly the problems that we had. Dr. Samira is going to present the challenges of emergency care in Barodico Teaching Hospital. Thank you.
While we're waiting for your presentation to come up, I think one of the questions in everyone's mind is, did the patient survive?
Unfortunately, we lost the patient exactly about a little less than 72 hours after she was admitted.
Okay.
Good evening, my senior colleagues. My name is Dr. Samira Muhammad Badamasi. I will present a 5-day survey through our accident and emergency. So through a period of 5 days, we had 5 cases of cerebrovascular accident, 1 cases of hyperglycemic crisis, which was hyperosmolar hyperglycemic state, 2 heart failure cases, 2 cases of acute exacerbation of peptic ulcer disease, 2 cases of heart failure, liver failure, end-stage liver failure, 2 cases of severe malaria, 1 case of gunshot injury, 2 cases of malignancies, 2 cases of fractures, 2 cases of acute abdomen, and a total of 87 outpatients were seen throughout that period of 5 days. 2 patients were discharged and we had 3 mortalities. So with a total of 107 patients. So part of the survey was to find out how many doctors and nurses were trained for BLS and ALS, of which we found out 2 out of 13 doctors in the medical team, 1 out of 10 doctors in the surgical team, none of the family medicine doctors, and 2 out of 20 nurses in the accident and emergency. So for the challenges, let's go back. I must start by saying Barodico Teaching Hospital is still in the transition. We were initially a specialist hospital, which we are the transiting phase of a newly reformed teaching hospital. So we still have a lot of challenges, though kudos to our medical director who has been working tirelessly and effortlessly to put things in place, of which these challenges have been tackled as some are on the pipeline. So one of the challenges of emergency care in Barodico Teaching Hospital Accident and Emergency Unit is limited bed space in proportion to patient load. Within Kaduna town, Barodico Teaching Hospital is the only teaching hospital. So a lot of referral centers from most of the specialist centers, the primary health care, they all come to Barodico Teaching Hospital. And we only have 20 bed spaces. And at this point, I also want to mention that the current accident and emergency we are using is a temporary arrangement. The accident and emergency we are occupying now is supposed to be a high dependency unit and an IC. So part of the solutions is that a space has been secured opposite the hospital in which a new accident and emergency will be built and will accommodate more patients. The next challenge is the need for training of staff in BLS and ALS. From the survey we had, and see barely 5 doctors, not up to 5 doctors had that training, and not up to 5 nurses had the training. Then the inadequate number of staff, usually in a rotation, not more than 3 nurses to 20 patients, and it's still the same nurses that will attend to trauma cases, because for now we don't have a separate trauma center. So the accident and emergency is for both medical and surgical cases. And to this effect, the hospital just had an interview to enroll more staff, which hopefully by the time they come in place, this challenge will also be solved. An inadequate resuscitative gadgets. We use mostly oxygen concentrators and cylinders, and with patients, a lot of things in place, they are usually not adequate. You can be in the A&E where 5 patients need oxygen, and you might only access maybe 2 cylinders and 2 concentrators. So the issue of who to give the oxygen and who not to give. Then the need for ICU and high dependency units, which I have already mentioned that our current accident and emergency was supposed to be an ICU and high dependency unit. So hopefully by the time the main site for the accident and emergency is built, the HDU and the ICU will kickstart. Then the need for an accident and emergency side lab for basic investigations. Part of the challenges in the case presented was mainly from the lab. Blood glucose was not gotten in time, serum EU creatinine delayed for 5 hours, which if there was a side lab, the investigations would have been faster. So to this effect, there is also an ongoing plan to get an accident and emergency side lab within this current accident and emergency we are occupying. And another challenge is recent transition to electronic medical record system. We used to go the old way, use of hard copies, folders, and the rest. But within late last year, we transited to the electronic medical system, which also has its hitches, and we're still battling with, though as every day goes by, it improves. Then inadequate emergency drugs. At times you need emergency drugs and they are nowhere to be found. Then other resuscitative gadgets like the ECG machine. We only get to have an ECG during working hours because the staff responsible to do that ECG comes in the morning and closes by 4. So after 4 p.m., you cannot access any ECG. There is none for now in the A&E that the doctors can actually lay their hands on the ECG, and the training also for the doctors and nurses to be able to do ECG, not that only one staff will run the ECG throughout the working hours. So in summary, as I said, we are a transiting hospital. We used to be a specialist hospital, now a teaching hospital. And with our hardworking MD, which is trying to place a lot of things into place, bringing new things, like now, currently they are installing the fluoroscopy machine, the mammogram, our MRI is working fine. We used to have the CT scan, which has gone down, but also process of getting it back is on the way. I think some of these challenges will be tackled hopefully. Thank you for listening and thank you for your time.
All right. All right, thank you so much for that interesting breakdown and analysis of the current problems that we've been facing back home. I think we have some questions on the chat box. Please, you can leave us your questions on the chat box. Somebody is asking. Okay, somebody says, why is establishing a side lab in the ICU and emergency unit a problem? Is the bottleneck the funds or lack of commitment from the hospital leaders? This is an advocacy issue that the NMA Kaduna should take it off. So, that's the question.
Okay. As I already said, there is plans on the pipeline to establish a side lab, which I think hopefully very soon we'll have one. The hospital is committed to doing so. As I mentioned, our CMD has been trying and is trying to put all things in place. Very soon we'll get to have a side lab in accident and emergency. There used
I think we're having some IT glitch over there.
Said yes.
Okay, there's another question here from Sadia. Sadia says, is BLS and ALS never done by the staff, or has it expired? Is there any basic recommendation needed before working in the emergency department? So taking a leap from the study you've conducted over there,
Yes.
Sadia is asking, is it that these staff have not, they've never had the BLS and ACLS done? Or is it that their certificates have expired? And possibly what arrangements have been done to have them renewed?
Well, the two doctors from the medical team have current BLS and ALS training. The two nurses in A&E, no, just one of them has a current one. The other one, his has expired. The rest of the team I mentioned do not have training. So we are trying to get, we're trying to get the hospital to maybe send or arrange a training. I think maybe it's a department thing, I'm not sure.
All right, thank you so much for that. We're going to take two more questions quickly. We'll take the one from Dr. Honor, and the question is, how many oxygen units does the ER have?
How many?
How many oxygen units does the ER need to be fully equipped? How many?
At least each bed, oxygen is supposed to be piped, it should work right, so each bed should have oxygen. Piped oxygen if possible.
Okay. And another question from Aziz. Aziz says, how many beds is available within the hospital?
The hospital, I don't have a data for that, but as for the A&E, we have beds.
All right, so I think let's just wrap up this particular session in the next 1 minute. Basically, from the explanation you gave and also the case scenario, I think there is the missing link. There's a missing link between the knowledge and the skills of the providers. The providers, I mean, the nurses, the doctors, those who work in these specialty units. There is a bridge that needs to be filled. Okay, so probably they have the knowledge, but the skills is also the issue. Because when you gave the analogy here, I realized that you mentioned the patient had chronic heart failure, and you were also generous with the fluid being given. So could that have possibly affected the condition? Just thinking. I think this should be a food for thought, because most of the time we are always generous with our fluid for cases that have to do with the heart. So I think that's one of the things we would have to discuss further.
I think in the interest of time, we need to move on to the next presentation.
Okay. All right. So let's go over to the next presentation now. That will be by Dr. Habib, and she's going to be taking us on the opportunities for improving acute and emergency care delivery. Okay, Dr. Habib, you have the floor.
Thank you. Can you hear me?
Loud and clear.
Perfect. Good afternoon, everybody, and thank you for joining us this afternoon. And thank you to Dr. Mariam and Dr. Samira for that insightful presentation. And I think on behalf of the acute and emergency medicine community, I have to extend our thanks to all those that deliver emergency care in sort of quite resource-challenged situations. So over the next 15 minutes, we're just going to go briefly to look at, when we talk of acute and emergency care, what do we actually mean? And then why should we consider acute and emergency care as a priority? And then what are the opportunities that are available? In terms of opportunities, I think I've decided to concentrate more at an institutional level because I think that's the low-hanging fruit of where your benefits might more easily be acquired. So when you talk of emergency care, essentially we're talking of any medical care, be it intervention, treatment that's given from the onset of an illness or injury through the first 24 to 72 hours. And I think that's critical to understand because that timing often starts in the pre-hospital setting. So your pre-hospital system becomes a very much integral part of an effective emergency care system. I think the peculiarities of emergency presentations is that they often have a time critical element. So when you talk of MI, you talk of time to thrombolysis or time to PCI. When you talk of stroke, you talk of time to thrombolysis for ischemic stroke. When you talk of sepsis, you have the golden hour of sepsis. And of course, for trauma, you have the golden hour of trauma. So all those are things to consider because your outcome in terms of morbidity and mortality depends on what you do in an emergency setting from pre-hospital through into your emergency department stay to the first 24, 72 hours afterwards. So why should we consider it a priority? There are many reasons really why emergency care I think should be a priority, but I've narrowed it down to three main reasons. One is over the last couple of decades, there's been an epidemiological transition with the decreasing prevalence of diseases related to infectious disease, communicable diseases, which is related to obviously the effort that or focus that has been put from a public health perspective. At the same time, there's also been an increase in urbanization and globalization in many of the low and middle income countries, which means that there's been a more westernized lifestyle change taken up. And that has increased the prevalence of non-communicable diseases. In 2016, the WHO estimated that 30% of all deaths in Nigeria were related to non-communicable diseases. So that's one reason. The second reason is to do with injuries. On average, globally, there are about 5 million deaths arising from injuries. 90% of this are in low and middle income countries. While I have tried to look for data for Nigeria, unfortunately, I was unable really to get to data. But certainly, I think anecdotally and observation, the number I would, from my conversations with people, it sounds as if trauma is also a significant emergency burden. So that's another reason why we need to consider emergency care a priority, because you've got a system, you need to have a system to be able to manage your traumas. The third reason I've put is related to the Sustainable Development Goals. The maternal mortality rate in Nigeria as of 2017 was 917 per 100,000. Which out of 186 countries, I think we were only surpassed by Chad, Sierra Leone, and South Sudan. Similarly, the under 5 mortality rate, the neonatal mortality rate, all of them are on the higher part compared to the global average. So, and most of these deaths in terms of maternal mortality rate and under 5 mortality is related to acute complications of pregnancy, acute complications arising from complications of infectious and communicable diseases. So I think those are three good reasons why emergency care needs to be a priority. We need to have systems established that will be able sort of to manage this to improve the outcomes, both in terms of morbidity and mortality for our patients. So this is just the take home from this graph, really. It's a World Bank graph that shows between 2000 and 2015, the transition that has happened in terms of more of non-communicable diseases becoming more of a burden compared to sort of the usual case or usual prevalence of infectious diseases and communicable diseases. In preparation for this presentation, there was a survey that was done in one of the tertiary critical care units in northern Nigeria between January and September 2020. And I think the main take home for me looking at this graph is that 2/3 of the admissions are related to more non-communicable diseases and trauma-related admissions. It is no surprise then that the mortality also, when you look at it, will be more related to those disease entities. Similar to what was done in Borodiko Hospital, there was a brief survey amongst the staff to see in terms of some mandatory skills, because whenever you're going to be part of a team that delivers emergency care, there is an expectation of certain skills or competences needed. So we looked at basic life support, advanced life support, pediatrics, and trauma life support. And that was sort of the data that we got. But for me, when I look at this data, I see the opportunities that are in there, because there's the doctor that has the BLS can easily support the rest of the team within that unit in acquiring BLS, basic life support skills. And certainly, while those that have ACLS might not be instructors, but they could support the rest of the team in developing unit-based training programs related to management of acutely deteriorating patients. So there are opportunities just looking at this slide. Right, we then move to opportunities. And briefly, I've decided to separate the opportunities into a national, state, and institution. And national, I'm not going to say much because that often relies on legislative changes towards making emergency care a priority. And I think I will bench that to the side because that is a discussion that will take a longer time. The other thing at a national I thought of was the national training program. And I think there does need to be advocacy for that, because that is the platform whereby if at a national level emergency care is deemed as something useful and a training program is put in place, then there is more likelihood that whatever is done gets spread evenly across the country as a whole and provides some degree of equity in terms of access to emergency care for all of the population. So that's all I'm going to say regarding national. When we go to state, again, there are many things that you can do at the state level, but I have selected just two. One is an establishment of a pre-hospital system, because as we've identified, the pre-hospital system is an integral part of an emergency care system. When Ghana, sort of our neighboring country, wanted to set up a pre-hospital system, what they did was look at what is the commonest route by which patients are brought to the emergency department. And they identified it was via commercial taxi drivers or commercial means of transport. So what they did then was provide some sort of basic training in first aid for the commercial drivers, and that provided them with a bit of a rudimentary form of pre-hospital system, and they gradually developed that up to the level that they were then subsequently able to develop a formal pre-hospital care system. So the question I have then is, we have a lot of tuk-tuks available. Is there any reason why we cannot innovate and think of tuk-tuk as a way of pre-hospital care? The second thing is identifying a center that you will make a center of excellence and provide or put in place all the emergency systems needed in there to serve the population. At an institutional level, we talked of training, and there are a couple of ways of doing that. Like we said, there are specialty mandatory training, life support courses, which in conjunction and collaboration is something that can easily sort of be set up to make sure all healthcare workers that are involved in delivery of emergency care have to have these courses. And then you have locally designed training programs that you have in terms of acute life-threatening emergencies, trauma. That's something that you can design. Digital opportunities, we are having this discussion now virtually. Certainly there is that avenue for collaboration between home and diaspora clinicians to sort of work together into developing training programs that can target acute emergencies. The next thing is system organization, and we talk here of clinical protocols. So standardized protocols are very useful in emergency care provision because they take off the cognitive load on whoever is providing that emergency care. So certainly there is room for developing of clinical protocols. System reorganization, look at your teams. You can get teams that respond to specific emergencies. So if you have a deteriorating patient, you can easily bring a team and train them towards being the first providers or rapid response teams. Crash teams are a group that you can work towards developing. And these are all things that really can easily be done. In terms of infrastructure and equipment, I think one of the things highlighted was things like ECG. So there are essential equipment that is needed to provide some degree of adequate emergency care. So your ECG is something, your point of care testing is something that you could explore. Pharmacy in the emergency department, do you need a radiology nearby? If not, if you cannot have an ED radiology, then why don't you have a system whereby images from the emergency department become time sensitive, they are prioritized? Workforce, innovate your workforce. We will never have enough doctors. So a lot across the world, what's been happening is actually upskilling other healthcare providers to provide certain aspects of emergency care that does not necessarily need to be provided by doctors. So your nurses are a huge potential of group that you can upskill. Collaborations are extremely useful. I will signpost to the African Federation of Emergency Medicine, whose one of their key interests at the moment is collaborations to help develop emergency care across the continents. So that's certainly somewhere that there will be a collaboration done. Quality improvement initiatives are essential, really, when you want to drive improvements, because what you want is you're not going to sort of try to make a huge change. You want to make small improvements. In the example of the patient that was presented, you can actually say, okay, over the next six months, we are going to work on improving the care we deliver to diabetic patients. Those infusion pumps are available. It's a case of how do we get, who will train people in terms of delivering the infusion pump. Let's make a management protocol for DKA and set indicators that will help you monitor those improvements that you are putting in place. One last thing I want to say is emergency care isn't something that waits. So your patients that genuinely are triaged as category 1 or category 2, they cannot come to emergency department and you tell them, oh, go and buy this. Often these people don't have money. So think of developing a hospital charity fund. Again, that is something that I've seen done both in the West and also in the Middle East. There is a fund. People want to sort of give to charity. Develop that charity so that when your patients come that are category 1, 2 and need immediate treatment and don't have money, then you tap into that, and that's a way of funding for those. The last thing I'm going to say now is fundamental to any improvement is leadership. There is nothing that's going to be impossible. And believe me that there are certain things that we have discussed today here that can be implemented within the next 6 months. But you need the leadership sort of to drive that. And certainly on discussions, I have seen evidence of that leadership across the board. So I hope that this is at least going to be like a launch pad of collaboration and interactions that will help us provide some improvement in the care of emergency patients within the setting that we work. Thank you very much.
All right, thank you so much, Dr. Shema, for that thought-stimulating presentation. There are some questions that has arisen from the comments box, but I think we're going to take that later on after the presentations have been made.
So we'll now go to the panel for discussion of the presentations that have happened today. So over to you, Dr. Sadiq, Dr. Olajide, and Dr. Salisu.
Okay, thank you very much. I think the presentation from Dr. Samira and Mariam kind of give us a snapshot of what happened at the micro level in a health facility. There's a lot more even at the micro level. We would have loved to know the story of this woman. Where is she coming from? How did she get to the health facility? Where is she being managed? Who is looking after her regular diabetic issues and hypertensive issues? Who is paying for that? What kind of support does she have around her, from the family, from the institutions that are around? So at the micro level, we can see all of that. But from my perspective, as someone who is interested in sort of systems level and policy level aspect of what we can do, I think we need to step back from what has been presented and ask ourselves some of the challenges that have been mentioned. if we had the most sophisticated A&E unit in Barao Dikko, the outcome would probably be different for the lady that was presented. But what does that mean for the rest of the people in the city of Kaduna? How about the people in the other sort of local government areas that are outside Kaduna? How about people in the villages in Kaduna State? So thinking about it that way, I think for me makes more sense. So for example, when you mention that you have limited bed space, how many bed space will be enough? We know even here in the UK, every year during the winter period, there's always problem with emergency beds, and ambulances queue up outside the A&E unit because there's no room in the hospitals to get the people in the A&E into the wards so that they can receive a new emergency attendees. If you think about training in terms of the life skills, life support skills that have been mentioned, how many, I mean, every clinician will need to have that training, but beyond clinician, I think it needs to go even wider than that. There are certain level of training that is needed even within the wider community in order to address what Shema in her presentation talked about, the pre-hospital side of things. If you talk about inadequate number of staff, will we ever have all the staff that we need? You know, so the reason why I'm pointing this out is all of those challenges that you mentioned are genuine, they are real, they are needed, but they need to be contextualized. And I think a lot of times when we want to intervene, we tend to think about having the perfect system first and then going out to deal with the problem that is in the context. I think a better way to think about it is to come from the context first. So how are people already dealing with these problems in that context? And how do we build the structures around what people are already doing so that it starts addressing for the majority of the population, not just a few individuals that selectively end up coming to our center. I think that's the way to start thinking about that. And in order to do that, we need to make certain decisions. First of all, who is eligible for emergency care? That decision is crucial. Is it open for everyone? And if it is open for everyone, who is going to pay for it? And how are you going to coordinate such systems that will collect the monies efficiently and also distribute it and allocate it in the right places so that all the people that we define as eligible for emergency services get them? So the second thing is, at what level of organization should we put emergency care? In Nigeria, a lot of things are done at the state level, but is state the ideal framework for organizing an emergency service? In this country, for example, I know A&E or ambulance services are organized by regions. And there is also a national coordinating mechanism that kind of bring them together. What unit of organization is appropriate for organizing emergency services for a country like Nigeria? Is a city like Kaduna an efficient unit to organize an emergency service, so that it doesn't matter where you are at any corner of Kaduna, if you have an emergency, you can get into the system and the system works seamlessly for you. So that's the second thing. The final point that I think we need to think about is what rules work in our system. What are the things that makes people behave? So if someone need to do a life skill training, what rules ensures that they actually get those skills? Is it at the point of recruitment? Is it at the point of renewal of your license? And if you don't do that, what are the consequences? Does having the skill, make any difference in terms of your progression in your profession or opportunities that are open to you? So thinking system wide, I think, is about thinking in these three different dimensions. First of all, starting from the environment, the context in which you're operating, and look at what organizational level should you start setting things up. Should emergency unit be looked at outside of the structure of the hospital, or should it be integrated within the hospital? That's one way to think about it. Should we so that's the organizational side of this. Second point that I mentioned, it's about what kind of frameworks and system do you want to have that will shape how individual practitioners and behave within the system. If they need a particular skill, they get them. If a particular item is needed, it is there. So I think thinking about it from a system perspective is what we need, and starting from what we already have on the ground. And I really like the example from Ghana, and I think we're capable of initiating something like that. That's where I'll stop for now.
Thank you, Dr.
Thank you very much for that, Dr. Sadiq. And also, I'd like to say thanks to Dr. Habib and also Dr. Badamasi and Dr. Lawal. That was an excellent piece of work. Going back to the case itself, there were a few things that kind of, hit me about the presentation, and I thought it was obviously is a resource limited environment, and it's almost an impossible environment to actually provide the best for your patients. There are certain things that I can't really figure out, because there's still an element of a diagnostic uncertainty regards this lady, based on the presentation. I know we've managed her as a sort of like a hyposmolar state, if I'm correct, but I'm not entirely sure we've got everything to be sure that there's nothing else underlying that. So what an interesting subject Dr. Habib has raised is that there should be an air of collaborative work, and people who are actually trained with life support skills should actually be involved with designing a program or a protocol around managing patients like this. And as you rightly said, Dr. Habib, that you can actually have a target set, because the idea of emergency care or acute medicine is that it's time critical. The key thing is this lady seems to have been in hospital for a period of almost 22 hours, and it doesn't seem her situation sort of worsened while she was in hospital. And that's the real worry. Apologies. So that's the real worry, that we have a situation where her sugars have not improved over a 22-hour period, and she seems to have started developing neurological consequences for that. So this is the thing. Where are this? We need to sort of rate limiting steps. People start to think in our situation, and whether or not our management is right, and that should trigger questions in us, because each hour counts. And I think there are elements or things we could have done, even despite the resource constraints, which I think might be hitting towards training, that could have probably made a bit of a difference, even might not in the overall change her prognosis, but might have made a difference to her. So an interesting thing, like also point of care, investing in point of care, like a bedside ketone monitor or an ABG machine, stuff like that could probably have guided management rather than waiting for full laboratory investigations with the user needs. Because to be fair, there would not be any that would serve to actually manage this lady better than actually waiting for repeat serum user needs from the labs. So if we had a sort of a point of care, which is not a big investment, and it seems like you have a fairly reasonable CMD or director over there who could put this forward. So things like that could actually guide the treatment, and designing a protocol towards managing this sort of patients in the future will be very helpful. There's a lot to speed out that could be done, but I'll leave it to my colleague to kind of take it from here.
Thank you, Dr. Olajide. Dr. Salisu, do you want to come in?
I'm really a bit scared anytime I get some information like that about patients. I always wonder if a tertiary hospital, if something like that can happen in a tertiary hospital like the Kaduna, excluding maybe Edu teaching hospital, that's the highest level of care we expect. So if something like that can happen to patients, what do you think of other general hospitals go down to the level of local governments, PSCs, and so on? So even though we are saying that Nigeria and other African countries are low-income countries, but I also look at it from another point of view, that our level of preparedness to emergency care is somehow questionable. Of course, all the challenges they have mentioned are there in almost all our hospitals. You see that there are inadequate manpower, where only 3 nurses will manage 30 patients. Certainly, you know that you are not going to get the best outcome. So that type of patient should have been taken care of by a nurse that will stay with her for every minute. If there's anything to look at the vitals and everything. But where you have 30 other patients and only 2 or 3 nurses, you cannot expect much from the nurses. So that issue of manpower is a real challenge. The proportion of nurses to patients, doctors to patients, and other healthcare providers, you see that is grossly inadequate. Second issue of inadequate equipment. Sometimes I just wonder, you go to an emergency unit, no suction machine, no provision for 12-lead ECG, oxygen supply is erratic. Sometimes you just see the cylinders, they are just there, 1 or 2 cylinders, they are empty, and no any attempt to refill them. You go to the A&E and see that there are so many other basic things which are not there. So it's almost, as far as our environment is concerned, a global problem which one has to worry about. The issue of sometimes the patients coming, you write some medications, you prescribe some drugs by right of investigations, which the patient cannot do. So you don't know what to do. And there is no provision from the hospital, no any provision from the hospital for the indigent patients. So you will be left with, sometimes you have to pay the money out of your pocket to assist the patients. So at the end of the day, you know certainly that there is a limit in which you can go. And the issue of issue of funding is something very, very important for us to look at. I think one of the things we look at is, you see, it's not difficult to provide oxygen, to provide a pipeline oxygen, sanction machine, ECG, and all these better things. What's expected of us is our commitment. I think one of our problems is commitment. If the managers, when our leaders are committed, the hospital can sit down, okay, what do we need to equip our A&E, accident and emergency unit? What do we need to equip our intensive care units and so on? A lot of things can be done. It's not beyond the reach of the hospital, but just our level of preparedness and commitment. Some, okay, fine, if you have come within a few hours, in the next 24 hours, you are said, and just like that, there is no issue of briefing and debriefing. What has gone wrong? How could we improve our situation? So if we look at it in that direction, so many things can be provided. Oxygen can be provided in our emergencies, not that difficult. Sanction machine, we can make it like in one of our hospitals. When we sat down with the management, what we did, we said radiology department, should be attached to the emergency department. There should be a lab, emergency lab within the emergency department, so that you don't have to run helter-skelter looking for RPS, which is there, and then you can get it within 5-10 minutes. It shouldn't take hours before you get random blood sugar and so many things, ECG machine, everything. So the radiology department, the lab, everything you need to take care of that emergency should be there. You see, in our A&E, hardly you see an external defibrillator, AED or manual defibrillator, which a lot of our patients can come down with MR and so on. So how much does it cost beyond the capacity of our hospitals? So if since are well equipped and we move to ICU, and up initial that patient, by the time her condition started, the GCS started deteriorating from 15 to 10, she should have been taken to ICU because the blood sugar refused to come down with the level of nurses patient ratio in the A&E. Patient should have been taken to ICU if there is one existing, or HDU, so that she will have a little bit better care. So I think if we look at it, we sit down, sometimes even though there is this problem of, but the planning, we need to sit down and plan these things. There is a need for the government issue of patients who are very indigent, poor patients. If this NHIS is purely functional, some of those patients who cannot pay, social welfare, other organizations within the hospitals, our associations can raise some funds and assist such patients. So if we have a very strong health insurance system, and there are a lot of philanthropists within the society who are ready to help. But sometimes when you talk to them, they say poverty has contacted them, this and that. So it's just that we have a lot of them. Please, we want you to provide us with ECG. We want you to build a lab within the hospital. They are ready to do that. So we can make sure that our emergency units and ICU are purely functional. We're going to reduce a lot of morbidity and mortality. The issue of training about BLS, ACLS.
Sorry, thank you, Dr. Salisu. In the interest of time, I have to stop you there so that we can go to the questions, and you'll get opportunities to speak and answer some of those questions. Thank you very much. So I'll start with one of the questions. We'll go to Dr. Shema. So one of the questions I was asked was that in low resource countries or settings, how would you go about implementing pre-hospital care without the government having to invest a lot of money in purchasing ambulances and maintaining the training of paramedics?
So I think often the mistake I see happen is we assume that what happens in resource-intense countries should be things that we take and transplant into our own settings. And I think often it's looking at our own prevailing circumstances and see how can we adapt what we have to achieve similar outcomes to what they have. So I think the example of Ghana was a very good way of doing it, because they knew that they didn't have the resources. So they started with just what is the way that patients come to them. So essentially, I think one of the fundamental issues we have at home in Nigeria is lack of data. So you often would need data to help you plan what interventions you need to do. So if I am to ask now and say what's the commonest route sort of bringing in maybe RTA patients into hospital, I'm not sure what that route is going to be. So my answer to that is really look at your own setting, look at what the data tells you. It's a pretty simple thing to do, and then utilize what you have. So the question I had thrown out to the audience is, we are inundated with tuk-tuks. I think they're called tuk-tuks. And is there any reason why we cannot think outside the box and innovate? Can we make use of some of those tuk-tuks as a way of transporting some patients? There might need to be some adaptation sort of to the structure of those tuk-tuks, but it doesn't mean we don't have to have ambulances as we have ambulances in the West. No, you just need a way of transporting a patient from an area where an injury has happened, or from a place where an illness has started, to your hospital. So first of all, start with transporting them to hospital, and then gradually you can expand what sort of things you need to put in place. Do you need to put oxygen? Do you need to sort of make sure they have some training in putting cannula? There's no reason why we cannot train non-clinicians sort of put cannulas, certainly here in the West. I don't do cannulas. Most doctors don't necessarily do the cannulas because we have healthcare assistants that get trained. So it's really coming together and having a conversation and see how do we work to develop I can't give you an answer and say this is what you do, but certainly I think coming together, let us know what you have on the ground, and then how do we adapt that to achieve the outcome that we want at the other end, which is getting patients in a timely way to hospital.
Okay, and a follow-up question to that was, what was the outcome of the Ghanaian approach? And some of the
Ghana now, I believe Ghana now already have some ambulances sort of in place, and there have been different models. If someone is interested, I can look at, because certainly I know in the East and Central African countries, because they've sort of had a focus on emergency care, there have been different models. So if someone is interested, ping me and an email, and I will certainly sort of send you different models that you can sort of explore. I can't hear you.
The audience is correcting you that it is called Kekena Pep in Nigeria.
Okay, my apologies, Kekena Pep, not tuk-tuks.
Okay, so next question, I would put this question to Dr. Sadiq.
Okay.
Do you see any role for telemedicine? That's one. And then how do we make sure that resource allocation is adequate?
Thank you. Yes, the quick answer is yes. Telemedicine is needed, not just even here where the emergency service is a lot better. They still use a lot of remote support to either the patients at home, or also clinicians going around houses to deliver sort of the initial support. In fact, there is a whole new movement around what is called hospital in the home. You know, I think it's quite well developed in Australia. I'm sure our colleagues that are in the US would also have a lot of that kind of things to share. In Nigeria, there are places, no matter how well your emergency transport is at the moment, the fastest they can get to any meaningful hospital will take more than a day. So if all you can get is at least someone on the ground receiving instruction on their mobile phone on what to do to save somebody's life, I think definitely we probably need it a lot more than we need it out elsewhere. I know countries like Rwanda, even though I haven't studied it very well, but I know that they are investing a lot in terms of telemedicine. So definitely there's scope for that. The second question was around resources, was it? I think
yes.
Yeah. So I think the issue around allocating resources, I think everybody can answer that. I think one of the questions that I always ask, and which I am sure every person working in a hospital in Nigeria will ask, is who am I responsible for? Who are my patients? So if I have an A&E unit at Barawdiko specialist, who is that A&E unit responsible for? Am I an A&E unit for everybody in Kaduna State? And what is my remit? What is my catchment area? And how do I ensure that I deliver the A&E that is needed by this catchment area? So the lack of definition of responsibility. So if you have an ambulance service, for example, ambulance service have their own catchment areas. So if emergency happen within their territory, they know that it is their responsibility to get there. And if they're overwhelmed, they can call in support from neighbors to come and help them. But in our setting, we really don't have any definition of who we are responsible for. And without clearly defining that, I think it is a lot harder, or almost impossible, I would say, to define what you need, what resources you need. So if Baraudico is responsible for emergency services for the entire Kaduna metropolis, the resources that they need is different compared to if they're only responsible for people that are in the neighboring community that are around the hospital. And it's a lot worse if they are also responsible for the entire state. So certainly there's resource limitation, but it is for an unknown need. So first of all, we have to know what the need that we are responsible for is before we can actually make an estimate or guess of what resources we need. And there are a number of opportunities, and I'm quite pleased that Dr. Magashi is here. I've been doing some fantastic advocacy work and pointing out to the 5% consolidated revenue, that 5% of the basic healthcare provision from which is drawn from consolidated revenue of the country. So this is enshrined in law. This money has been collected. It is being collected every day, and it is accumulating somewhere. And 5% of that money is supposed to go to emergency services. And we haven't, as a country or as intellectuals within our country, found a way of holding our institutions to account for even things that we are entitled to within the law of the country. So this money is there. What has it been spent on since the money have started accumulating? How much is it? How much is the money now? The same thing with NHIS. NHIS has been there for 15 years. Do we know how much money have been collected since NHIS was established, and what has that money been spent on? You know, and we know that every year there is money that is being allocated in budgets. Do we know how much of that money was used? What is the money used to pay for? You know, so first of all, we have to know what our responsibilities are in terms of the needs that we need to provide for. Then we'll be able to have an estimate of how much resource we need for that. Secondly, we need to understand and also put pressure on the resources that are already being allocated, that they are being utilized in the right way. So I'll stop here.
Thank you. Dr. Otuama, you have your hand up?
Yes, hi. Sorry, there's an ambulance going by making noise. Thank you so much. I've totally enjoyed this presentation. Thank you to Dr. Shemil for Dr. Habib for that awesome presentation. I agree that, you know, the community needs to do some data analysis to decide what are the short-term and long-term goals. You know, we keep writing and strategizing. I think, first of all, oxygen is critical. I can't think of any condition that oxygen is not the first line of treatment for. I think that this is a national problem in the country, and it's actually one of the reasons why I left, because there's no reason why a hospital should have no oxygen. Now, there are grants, there are international grants that can be tapped into if we cannot get, and like someone had earlier said, to connect oxygen is not difficult. I mean, they are the small oxygens, even if the pipes are not working because of age and institutional damage or whatever, there are small portable oxygen tanks that my patients use in the US. I think that if, you know, with the condition or based on a data analysis or survey that the hospital or ER department does, they can easily get grants. So there are opportunities. We need to maximize those opportunities. If we cannot get support from our government or from private institutions, you know, I think it's important to always have oxygen. That is key. I can't count the number of people who have died from just a lack of oxygen. It's a basic need. It's like breathing air. So I think that's something that the ER needs to do. Thank you.
Thank you, Dr. Otuama. Next question is to Dr. Olajide. Aziz, are you still there?
Yes, I am.
Okay, it's the question is on whether you think there will be any challenges to extending physician-specific training to non-physicians. I'm sure you work with people like
the simple answer is I don't see there are challenges, but I don't think that I don't see that as a negative. I think it's actually it should be exploited as we've hit on the previous presentations. And it's all about, as I said, we have to be innovative with our workforce. We have to be ready to utilize what we have, because obviously resource is always going to be a problem, and money is always going to be an issue. Even in the most advanced healthcares in the world, you have to be innovative with what you have, and utilizing extending a certain aspect of management to of care towards non-medical people is actually would relieve the doctors to do other things that they should do, and would help. And it's about understanding your workforce. So it can't be a one cap fits all kind of approach. It has to be done based on your own local needs within your own area. So that's the only way to look at it. It's about understanding your own environment and your own system to begin with. And looking at that, what you can actually do is learning from your mistakes and learning from your errors. And it would be good if, where the case was actually presented, if cases like this were as part of a morbidity, mortality, and a learning event, so that then from there can be ideas generated locally towards how do you upskill people and how do you involve other non-medics in towards management of patients in general.
Thank you. So I have a question for Dr. Salisu. How would you make sure that BLS and ALS training and retraining is a requirement in your hospital for all healthcare workers?
I need to unmute.
Okay.
Before you commence as a healthcare practitioner, you must have at least BLS or CPR certificate. Contrary to our environment, you start working as a medical officer or resident without having any certificate. So I think it should be made mandatory for any healthcare practitioner. So in our own case, when we realized we have this problem, I was sponsored by my institution, and I got a provider certificate of BLS, ACLS, and BLS PALS. And then subsequently, I was also courtesy of Smile trained to become an instructor of BLS and PALS. So when I came back to the hospital, I made it mandatory upon myself that on monthly basis, we train some number of healthcare personnel, clinical and non-clinical staff across the hospital and within my states, from the Ministry of Health and also from my hospital. So on a monthly basis, we organize a program like that. We invite some number of clinicians and non-clinicians to come and learn at least BLS and get the certification. So we continue with that, hoping that after some time, God willing, we're going to train a lot of our healthcare personnel. And also we introduce a program whereby we go to the general public also to teach them the lay rescue, your CPR. So that's also going to help a lot. Since we don't have active emergency, ambulance services, no any number to call, whatever, you have to start looking for a car to take the patient. So, but if the general public are taught how to do CPR, they can start helping their relatives before they reach the hospital. So I think by making it, each hospital should try to emulate our own, send some of their representatives to go and learn BLS, ACLS, and so on. The training doesn't cost much, so that they can come back and replicate and teach other healthcare personnel within the hospital. Thank you.
Thank you. So the last question I'll put to a non-panelist, Dr. Shakir Balogun. I can see you on here.
Oh, somebody mentioned my name now.
Yes, your name has been mentioned. I'm putting this question to you.
Okay.
Do you think there is a role for regulatory bodies in ensuring that mandatory training or other essential skills must be met by practicing professionals?
Well, I think maybe through the registration council like MDCN and maybe the Nurses Council, things like that can be done. So I think it's just a matter of advocacy and getting to talk to people. They have the powers, to regulate training, certifications, requirements for jobs and the rest of that. So I think there is a possibility.
So how can that be done then?
Well, I can't say that now, but it's something. I really can't say it, but it's something that we need to explore so we can be clear about what exactly needs to be.
Thank you very much. Right, thank you to the presenters and the panelists. We'll just talk briefly about our patient that, in an ideal situation, we expect that we have a center of excellence or many centers of excellence that have been set up all around Nigeria. And this lady presented to one of those centers of excellence, and she, from the beginning, say her family would have called an ambulance as she was unwell, and the paramedics would convey her to the hospital, providing some initial care while in the ambulance before bringing her to the hospital. In the emergency care, she will receive immediate care because she will be the team will be expecting her. There will be point of care testing. She will have had things like portable chest X-ray. Her blood test will come back soon. She will have access to critical care review. And because of her history of heart failure, in addition to having what sounds like a hyperosmolar hyperglycemic state, then she would be managed in a high dependency unit where she would have some vasopressor support. She will have continuous venous pressure monitoring, continuous blood monitoring, and in a few days, this lady will turn around and she will be discharged home. We know that it's not impossible for these things to happen in Nigeria. In life-threatening conditions, we know that prompt response is key to improve survival, and flying out of the country for treatment in an emergency is not an option. So implementation of emergency medicine training, as well as setting up emergency response services, is essential. We have opportunities for collaboration with those in the diaspora, as well as those that are working locally, dealing with these challenging situations. We know that the staff are doing their best, and with the right leadership and motivation, it is possible to develop centers of excellence in Nigeria. Okay, thank you. Thank you, everybody.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
Okay.
Yeah, thank you.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.